Hey class, so now we're going to cover our part two of human movement science, and we'll get into a little bit more granular detail on the terminology and concepts so that we can have a conversation around movement. Once we sort of get into the exercise physiology, what I really want to do is make sure that we have a fundamental understanding of how we discuss and talk about movement from an exercise perspective. And also, sprinkled in here will be a few other little tidbits of information I think will be relevant to anyone who's interested in exercise science. Ooh, okay, so now my my face is cut off a little bit. I was trying to get creative with some of the there we go. Trying to get creative with some of this. All right, so I got to keep here. So these next three slides are in your PowerPoint. I'm not going to go through them. These are terminal. This is terminology that you need to know as a kinesiology major. My hope is that many of you plan on going to bachelor's level. If you're not there yet, that should be the plan. And so these are all terms that you will be exposed to in upper division coursework, 300, 400 level courses. So it's really important for you to know this now. This is one of the things that I constantly do with all of my students in my kin major courses, is to teach this terminology and this language. I'm not going to run through this. There's nothing for me to teach other than you have to know this. I'm going to start talking about these terms in other presentations that I post up. And it's really, really important that you're familiar with them. So your quizzes will test you on this. So it's really, really important to work towards this so that by the time you get to the next level and or you're in your current level, which may be working with clients and things of that nature, or working in as a physical therapy aide, working as personal trainer, strength and conditioning coach, working in the sports med in our sports med program. This is all terminology that you're going to need to know. Okay, so we have more content here, so please make sure you spend the time learning this material. We have a little bit more here. Okay, now we're getting into other ranges, basically descriptions of how do we describe movement. And I'm going to break this out here in the next few slides, but I'm just not going to define each of the terms for you because that's something you should be doing on your own and memorizing. Okay, and then the last two are here. All right, moving on. So now we have a concept called, obviously this is a skeleton. We talked about this a little bit earlier. We talked about the joint by joint approach. But what we need to make sure we understand is just from a more of a 500-foot level perspective, the skeleton. We have what's called the axial skeleton, which is going to be the skull, the spine, the ribs, and the sacrum. And obviously multiple bones here. The skull is not a single bone, but multiple bones that have fused together. Generally, should know that we have over 206 bones or have 206 bones in the body. And this is going to be the axial skeleton in blue here. The appendicular skeleton will be everything else. So you're going to see what's in blue here. Now the pelvis, obviously the femur, the tibia, fibula, the metatarsals of the foot, metacarpals of the hand, radius ulna going up the chain here from the hand into the humerus. In looking at the ribs there, you see on the back side of the ribs, the scapula, and you see the clavicle. And then you also see the humerus, and we'll talk a little bit about that. This is going to be the shoulder girdle. All right, let's get into a little bit more depth of the spinal column because we do need to have a good fundamental understanding of this. Each section of the spinal column moves a little bit differently. We talked about the mobility stability model and the joint by joint approach. So you're going to see, if you look at the lower portion, the lumbar vertebrae, you're going to see that there's 5 of those in pink. And what you'll notice is that they're thicker. They don't want to move side to side. They're going to move forward and backwards. So think of more flexion oriented. That's going to be the lumbar vertebrae. There's 5 of those. The next one is the thoracic vertebrae. There's 12 of those. That's in green. And you're going to notice it's a little hard to see here, but if you ever want to take a look at some other pictures or look at any anatomical models of the spine, which I highly encourage you to do, you will see that the bony protuberances on the back side there, on the other side of where it says thoracic vertebrae, they actually lay a little flatter on top of each other. So you get a little bit more of not only flexion, so flexion extension, but you're also going to get rotation and you're going to get lateral flexion out of that part of the spine. So again, structurally a little different. And then the cervical vertebrae are going to be the smallest ones, and there are 7. And they give you the greatest range of motion, obviously, because we have to move our head and neck. So they do flexion, extension, lateral flexion. This is an important aspect to know, obviously, from a movement perspective. So let's go back to this for a second. Now, you might say, well, how am I going to remember this? We use the acronym breakfast, lunch, and dinner. And I know, just go with me here. This breakfast is the first meal, so that's going to start at the top. That's the cervical spine is at 7. Lunch is at 12, and dinner is at 5. And so that's the easiest way to remember that 7, 12, 5 relationship. The next piece of this we have to understand is the discs. So the yellow-white material in between each of the vertebrae, the bones, are the discs. Now, we have to identify that too. So what you'll know or what you'll learn is that the first and foremost, we go from the top down. So let's start at the very top. There's 7 cervical vertebrae. So the very top vertebrae right under the skull there is C1. The next vertebrae is C2, and that stands for cervical. C3, C4, C5, C6, C7 is the last cervical vertebrae, and then we go into the thoracic vertebrae. So that's going to be T1 all the way down to T12. And then the top lumbar vertebrae, the very first pink vertebral body, is going to be, maybe you guessed it, L1, L2, L3, L4, L5. Now those numbers and that order matter because we describe the discs between the vertebrae. So as either, and we'll use lumbar spine. So let's use the very last lumbar spine, L5. And let's say you have some disc issue in between the one above L5. It's going to be L5 or L4, L5. So L4, L5 would be the space between those two vertebrae. Now, what's not on here, and it's important to look at the very, very bottom in yellow there, is the coccyx, or the sacrum, and the little vestibular tail is the coccyx. We'll talk about that in a second. But there is a vertebrae between the sacrum and L5, and sacrum is referred to as S1. So I know that's not on there. It's just something you're going to have to kind of remember. S1, L5 would be the disc between the sacrum and the lowest lumbar vertebrae. So that's an important thing to understand in how we define or how we identify some structure in the body. And then we will move on. All right. So next I have that same vertebral body. But what's interesting about this is you're going to look in the cervical vertebrae and the lumbar vertebrae, the curves go backwards, whereas the thoracic vertebrae, the curve goes forwards. Okay, so they have opposite curve patterns. And if we look at the fetal dynamic, the fetus, in the developing child in a womb, we're going to see 9 weeks all the way up to 40 weeks before they're ready to be pretty much born. The shape of the fetus is in the shape of the C, so that you've got that C curvature. Now you look back at the spine on the right, you'll see only one of those curves is actually a remnant of what we call the fetal position, and that is the thoracic spine. So the thoracic spine, as we maintains its curvature, its forward curvature. However, we see the cervical vertebrae and the lumbar vertebrae have to develop these curves. So part of the developmental process from being born into walking requires all of us to develop our cervical curve and our lumbar spine curve. And those are called lordotic curves. The thoracic spine vertebrae is called a kyphotic curve. So kyphosis, or the act of being more in a flex spine position, is going to be sort of a natural default position. If anyone's ever stressed out, we joke sometimes like, oh, they're in the fetal position. That's a very comfortable position because it's a relic of our abilities or where we were in the womb. But we have to develop the lordotic curves of the lumbar spine and the cervical spine through the developmental process. And usually they start happening around month 4. And then we start to do some other developmental things, and that's a whole different course. In our functional anatomy course, our Kin Major 102, we'll cover all sorts of functional anatomy and how we get up, how we develop. It's called human movement anatomy, I think we're calling it human movement anatomy. But it's also in the upper division. It's Intro to Human Movement Anatomy. It's called a functional anatomy, and that's going to be a new course that we hopefully are going to be offering this fall. This is 2025, just to kind of reference this because I know what's going to happen is I'm going to keep this video going, and I want to make sure that the folks who are already in the program that actually see that course think, why are you talking about it? It's already happening. But in 2025 spring, when I'm recording this, that course is technically hasn't been offered yet, but I'm hoping, fingers crossed, either in the fall, if not the fall, definitely spring 2026, we will have our Kin Major 102, Introduction to Human Movement Anatomy, which is functional anatomy, and we will cover a lot more structural stuff, some of this stuff as well, but we'll get into greater detail on that. And it's all about human movement exercise and how the anatomy operates. Just like the physiology is its own thing. Generally, we have gross physiology, all of the cellular function, but we're going to get into a little bit more of exercise physiology in this course so that we can kind of learn a little bit more about what happens to the systems that we need and operate us through exercise. Okay, so that's just a little bit about the spine, a little bit more about functional anatomy, which we'll get into at a later date. All right, now one thing to just kind of look at here is over time we might say, well, I get that we develop these curves, but we can obviously lose the curves if they're not maintained. So what you're seeing here is what we call neck creep or head forward head creep. And what you see in normal posture on the left-hand side, that the head is about roughly 12 pounds. And you see that the ear, if we could imagine an ear there, is sort of lined up above the shoulder, a little bit more in front of the shoulder. I'd say ideally we'd want that head a little bit further back, but generally pretty good posture for a diagram. And then now we're going to move 2 inches forward that same head because of the weight of the head now is actually hanging out anatomically and gravitationally is pulling us now forward. We have a lot more vertical, really shear on that posterior side of the upper spine. And now that weight turns into 32. And if we move 3 more inches, or 3 inches total, it's now 42 pounds. And so you might wonder why do elderly folks, or why do I see older folks who have, their posture seems to deviate? Well, it's actually a return to that kyphotic developmental position that we had. And we have always heard, hey, stand up straight, you got to have good posture. This is why, because poor posture will negatively impact the movement system. And again, we'll unpack this a little bit more in some of our other coursework, but I think it's important just to kind of give everyone this foundational information and knowledge. Okay? All right, next we have the sternum and ribs. There are 12 ribs on each side, so a total of 24. You're going to notice the very, very bottom, the rib 11 and 12. Those ribs are floating ribs, so they're not attached to the rib cage. And just something to observe. Sometimes you feel them. You might say they're a little different. Yeah, they're floating ribs. And then we have the sternum, which is made up of 3 components. Really, the bottom of the body of the sternum is that chest plate right on the chest here. We've got the clavicular notch the manubrium. That's going to be the upper portion. And then the very, very bottom is like a little bit of a floating bone called the xiphoid process. The sternum ribs and things can crack. And I always talk about this in some of my other courses, but if you ever have to give CPR, you will most likely crack some ribs. And or the sternum and or the xiphoid process can fracture. So that's normal. So don't be freaked out if that happens. But I think it's always interesting when we look at this anatomy to say, hey, what, this is, we don't talk much about the ribs because they kind of just hang out there. Now, here's the other piece to this. Ribs, much like the rest of the body, need to move. And I don't really get into this. I don't think we'll get into this in this course, but more in the functional anatomy course, we'll talk more about breathing, the importance of breathing, and what dysfunction can happen. And certainly in our corrective exercise course, our Kin Major 218 course, we talk about what can happen to the human movement system when breathing is suboptimal, not operating correctly. That usually means the rib cage is going up, and that starts to actually create more stress on the vertebrae in the T12 L1, the thoracolumbar junction between the last thoracic vertebrae and the first lumbar vertebrae. And that can create some extra stress there. And so rib mobility becomes an important aspect because think about the rib cage, it's actually attached to the thoracic spine. And we're going to see here in a minute, thoracic spine is where we get all of our range of motion in all three planes of motion, which we'll talk about here in a second. Pelvis, I don't really want to get into this too much detail, but you can see that it is much like the skull. It's a series of parts that are fused together. And then, yeah, that's all I really want to get into at this point. Okay, the legs. So obviously the pelvis, hip joints make that up, but I'm focusing on the femur, the tibia, fibula, and the patella, the kneecap. And those are the big takeaway bones that we have to focus on here. Now, you're going to see these flashcards. These are just moments to stop. And if you're looking for something to kind of study from, these are what these flashcards are. All right, so now we have to move into planes of motion. And this takes time. And this takes you, especially in an online course, spending some time with this. I've got some videos here that you can watch. Not in this not in this presentation, but go to the PowerPoint that I have. The videos are in there. I think those are very helpful videos, and the next 3 slides will help you with that. But the big thing to understand here is that the body moves in 3 planes of motion: the sagittal, frontal, and coronal. And you have to imagine when you look at the transverse, not the coronal. Sagittal, frontal, and transverse. That's how we typically use it in kinesiology. Some of you, if you've taken anatomy, might have heard the coronal and the horizontal planes. In kinesiology, we don't typically use those. We say frontal and transverse. But those will be some overlap. If you've taken anatomy, or if you haven't taken anatomy yet, you will get that. You'll hear them interchange frontal and coronal, and probably refer to coronal instead of frontal, and horizontal instead of transverse. But for our purposes, it's transverse and frontal. All right, so let's look here at the body, and we're going to break this apart in the next in the next slide, so it's going to be a little easier to see. But the sagittal plane is going to be the plate of glass. Just think of these as these plates of glass that are dissecting the body. So movement that happens in the sagittal plane is going to be really up and down, forward and backwards. A lot of our movement happens in the sagittal plane. The frontal plane cuts us in front and back halves, the anterior and posterior halves. And the transverse plane, you're going to see it cuts across the middle there, and that cuts us in upper and lower. Okay, so let's go on to the next slide. It's a little easier to see. Here we have broken it out for you, and you'll see that the frontal plane is much easier to see. The sagittal plane is much easier to see in the transverse plane. So I want you to watch these videos. So go over to the other PowerPoint. I'll put the links in here as well underneath so you can just access them as well. But I think these are helpful videos so you can start to see movement that's happening in these planes of motion, because we're going to describe it here shortly. So the next 2 slides, I'll show you 3 slides. I've got this plane of motion video number 1. Then we have a plane of motion video number 2. There that is. And then we have joint action, which is a little trickier. We're about to get into this, and I'm going to do my best to talk through it. But this is stuff you're just going to have to memorize so that we can have an intelligent conversation speaking about movement as we discuss exercise physiology. All right. So hopefully you've gotten through those. At least they give you some background. Now let's look at the possible joint actions. So we've got 13 possible joint movements. And you're going to see on the right-hand side the key. Each plane of motion has, or each plane has specific motions that occur in it. So flexion and extension happen in the sagittal plane. Abduction, adduction, eversion, inversion, lateral flexion are going to be the frontal plane movements. And the transverse plane is going to include horizontal abduction, horizontal adduction, rotation, both internal and external, and circumduction, which is rotation around a point, fixed point. Supination, pronation happen in the wrist. So we're going to break it apart here now and look at each individual set of joints and how they move. The reason why we teach this is we want to look at the plane of motion first, and then from the plane of motion, we will figure out what joint action is available to us. Many of you work out in the gym, I'm sure. Many of you might aspire to work out in the gym. And what you'll find is that often there is overuse in one plane of motion, sagittal typically, and a series of joint actions. So let's talk about just use flexion and extension. I'm going to, because you can see it, I'm going to give you my head and neck. Okay, so my neck is, this would be spinal flexion of the cervical spine. This would be spinal extension. Now, let's just say hypothetically, if I do 100 neck flexing exercises, doing neck flexion, if I do 100 of these, and I only do 50 the other way. Now, we know that there's muscles that are doing this, but what will happen over the long haul is an imbalance will develop. And if I have overly worked these muscles, sternocleidomastoid, my neck flexors, and then I have a bunch of neck extensors, these will become underactive, weak. These will become overly active and tight. And if you're on your phone a lot, right, you're getting a lot of neck flexion, and you may not be strengthening the opposing side, and you can overly develop or overdevelop one side of the body and need to counterbalance it with the other movements. So when we're working with exercise, it's important to know how many times are we moving through one plane of motion and in one specific joint action, or several joint actions combined through an exercise, because I want to make sure I balance that out so that I don't overly develop one side of the body over the long haul, which happens very frequently in traditional gyms. And it usually will lead to an injury of some kind. All right, so let's start with the shoulder. There's 9 movements of the shoulder. And let's see if you can see me here. Shoulder flexion. This is shoulder extension. Shoulder abduction. Abduction is away from the midline. If you look at the definition, as you remember, adduction is shoulder adduction towards the midline. The midline being the center of my body. Okay, and then we have horizontal abduction. So that is going to be across the transverse plane, away from the midline. And then we have horizontal adduction, back to the midline. Whenever you see horizontal, it's always going to be transverse plane. That's why it's in green. Then we have internal rotation, external rotation. So internal rotation of the shoulder, external rotation of the shoulder. And then circumduction is going to be around, shoulder moving around a fixed point. So in this case, it's the humerus moving circular around that joint. So that is, it's always a little easier to do this in face-to-face. But the other piece to this is when you know the plane of motion and the joint action, there's going to be a certain relationship to the certain amount of muscles are going to get recruited. So each joint movement involves a different set of muscles, even though particular muscles may not be exclusive to a particular movement. So we'll have some overlapping muscles that work in different planes of motion and different joint actions. That's fine. That's normal. But generally, we look at when we're trying to balance out movement, we want to make sure that if we're moving in one plane of motion in one particular joint action, we want to make sure we have an opposing joint action to that, so that we can make sure we don't build and create any imbalances in the system. Now, this opens up a different kind of conversation. Well, what if I'm doing a whole bunch of other stuff and I'm overly developing one side of the body, let's say through work, through repetitive tasks such as being on your phone, right? Well, then you might actually have to overly develop the other side. And that comes down when we get into exercise prescription, which we're not going to do in this course per se. But when we build out an exercise program for someone, whether it's a rehab program where we're trying to fix something, whether it's a fitness program for a general population, or it's a strength and conditioning in athletic populations, we still want to make sure that we're developing balance on each sides of the joint and each sides of the joint action through the different planes of motion. So that becomes really, really important. All right. So we talked about the shoulder, but what we forgot, and you can see it right over there on the right-hand side, you see the humerus. That's going to be you see the lower one. It says humerus right there. That's the big bone, the shoulder bone, or the top part of our arm. And then it goes into what you can see up above that is scapula. That's our shoulder blade. And then the scapula has a couple parts to it. At the very top, you see the acromion. So if I just find the very tippity top of the edge of my shoulder, that's actually the acromion right there. And that goes into another bone, the clavicle. So you have really 3 bones in all of the tissues, the tendons and ligaments and muscles that hold, and fascia that hold that bone together, those bones together. And that's what we call the shoulder girdle. It's all of it together. Okay. So we do need to talk about the scapula. So let's move on to the next slide here. And the scapula has a certain set of things it needs to be able to do in order for the humerus to work. If my scapula don't do their movement, and we'll look at that. So here's my shoulder blades. Let's do it like this. They should elevate, they should depress, they should protract, they should retract, they should upwardly rotate and downwardly rotate. And if they don't do that through the range of motion of whatever's happening at your humerus, you start to run into, again, some underactivity and overuse potential. We call the relationship of movement of the shoulder blade to the relationship of the humerus, it's called a scapular rhythm. There is a rhythmic nature that the shoulder blade should do as it relates to the movement of the humerus. The challenge is we don't look at scapula all that much. We might occasionally see one on the beach. I always joke here in Hollywood, we sometimes see at the red carpet events, the low strap, the low cut dresses and things, and sometimes you'll see scapula popping out. That's what we call winging scapula. That's a dysfunctional scapula. And anytime I see that, I'm always like, that's so gross. So winging scapula is something that's needs to be fixed. There's some inherent muscle weakness in particular with the serratus anterior group of muscles that hold down the shoulder blade up against the rib cage. And that's just dysfunction, and that should be fixed. Because if that scapula doesn't have its ability to move, it doesn't want to be hypermobile as we saw before. It needs to be more stable. So if it can't come down against the rib cage, it creates instability in the shoulder, which then throws off the rest of the kinetic chain. All right, so a couple other things about this PowerPoint. So when 2 muscles work together, that's what we call forced couples. When 3 muscles are working together synergistically to kind of facilitate movement, that's a forced triple. So we have this relationship, the bullet 5 or number 5, we have a relationship between the humerus and the scapula. And let's take a look at what this is. So, and next slide, we'll look at actual pictures. But what we've got is sagittal plane, shoulder flexion, shoulder extension. So now I'm going shoulder flexion, shoulder extension. What should happen? When I do shoulder flexion, scapula protracts and elevates. And when I do shoulder extension, it's going to retract and depress. So we get protraction, elevation. It's going to kind of open up and go up. And then it's going to come back down. It's going to come down and retract. And you can feel when you bring your arms all the way down and kind of backwards towards away from your chest, you should feel your shoulder blades squeeze together. The frontal plane, shoulder abduction and shoulder adduction. So here we go, abduction away from the midline. I should get upward rotation and elevation once my arm breaks 90 degrees. And then when I do shoulder adduction, I'm coming back down to the midline. I'm going to get the opposite of that when I'm going to get downward rotation and depression of that shoulder blade. And the last one will be shoulder horizontal abduction. So abduction is this way, away from the midline. So you're going to see my arms here coming away from the midline. And what I should get in scapula when I do that is scapula should retract. And then when I come back together, scapula should protract. So let's take a look at this a little bit more visually in the next slide. Okay, so here we are. You can see at the bottom, under each of these, under the woman, you're going to see the elevation. Depression is number 2. 3 is adduction. 4 is abduction. 5 is downward rotation and upward rotation. So let's go back up now. Look at number 1, elevation. You see her right shoulder, she's raising it up. That's scapular elevation. Okay, so scapula comes up, so does the humerus. And then the opposite of that would be scapular depression. So shoulder blade is coming down, sliding down. Sometimes I'll use the coaching cue. I want you to slide your scapula down into your back pockets. So you're trying to squeeze them together, bring them down. And then we see adduction of the scapula. So you're going to see she's bringing it, what we're going to call retraction and adduction are the same thing. So scapula is coming this way. She's like doing a row, and she's retracting her scapula. And then abduction would be coming back on the other side of the row, or doing a press or a push-up. The shoulder blade is going to protract. So protract and abduction and retract and adduction are the same things. And then we have downward rotation. So that you can see she's bringing her arm all the way down, and now she's from the upper position downward here. We're seeing the scapula do this, and then we have upward rotation on the far right. That's the other scapular rhythm. So they all work synergistically, meaning that if I go one way, they should go the other way. But here's the thing. Sometimes people's scapula don't work as well as they should. And that creates, again, a mechanism for injury potential. So it's, as human movement professionals, it's important for us to understand this depending on what path you go, whether you're a personal trainer, strength coach, or you plan on going on to, fitness professional, and or group X, and or think about strength and conditioning, working with athletes, think about occupational therapy, which is working with folks, physical therapy, working with folks in a rehab setting, occupational work with folks in a rehab setting as well, but more about activities of daily living. So all of this stuff matters to our discipline, and then certainly with athletic training, you're going to be rehabbing and correcting and strength training, and you're going to be doing everything. So you have to have a good understanding of all of these things in your field. All right, so let's look at the spine. The spine has 5 movements. So because it's flexion, extension, forward and backwards, you're going to see that on the lower right-hand side. Flexion, extension, that's sagittal plane movement. Lateral flexion is going to be the one lower left, and lateral flexion to the left, lateral flexion to the right. Both sides are called lateral flexion. And then rotation, you're going to see at the top, is turning away, rotating your torso. And then circumduction would be if I was going to kind of rotate my spine around a fixed point like that. That's circumduction. Okay, so moving on to the hip. Now we have good old-fashioned hip. We've got all of the movements out of the hip. Remember, the ball and socket joints move the most, so we're going to have the most amount of freedom in there. We should. And so we see flexion, extension. So look at the lower, the skeleton at the bottom on the left-hand side. Bringing the leg forward, the humerus forward. That's going to be enclosing the angle between the hip itself is going to be flexion. Extension will be bringing that femur backwards. That actually increases. And one of the definition of flexion is closing the joint angle. So let me get you over here for a second. So when I do elbow flexion, which we're about to do, the joint angle gets smaller, shortening the joint angle. Elbow extension is when the joint angle gets bigger. So we have to think about where is the joint angle getting bigger and where is the joint angle getting smaller when we're talking about flexion extension. So you see over on the left-hand side, hip flexion, that femur goes forward and potentially up. That would close that angle in front of the hip. And then when you bring your leg back down or from the forward position, it will open that front part of that angle across the hip. Now, abduction, adduction, that's going to be frontal plane. And so you're going to see abduction away from the midline. Again, abduction just as a mnemonic device. If you're abducted by aliens, you're taken away from Earth. If you're, that's usually, I also use the If you're abducting my child, you're taking my child away. I'm going to come get you. But that's an easy way to remember. Abduction is away from the midline in our case. And then therefore adduction is going to be towards the midline. So you're going to see the hip in the middle, two skeletons. Abduction is going to be hip moves away from the midline. Adduction is going to be hip moves towards the midline. And then we have, not in here, but we have, the last two, internal, external rotation. You're going to see now the ball and socket is spinning. So the femur is spinning inside of the joint of the hip. And one is going to, when your foot goes out, it's going to be external rotation. When your foot goes in, it's going to be internal rotation. And it's not the foot so much as it is the ball and socket is what's actually rotating, which should be expressed by the foot. But we're really talking about the hip itself. The last two, horizontal abduction, horizontal adduction. So I'm going to show you here. Let's see if we can get, it's hard to see. So think about, here's my knee right here. Here's my leg. This is going to be horizontal plane is in the transverse plane. So horizontal abduction, horizontal adduction. Okay. So thinking, I hope that you can see that okay. But horizontal abduction, horizontal adduction. Ooh, I think I'm losing my picture here. Might have just gotten too dark. That's okay. And excuse me, that is the transverse plane movement, okay? And then rotation is always going to be in the transverse plane, so internal rotation, external rotation that we already talked about, and then circumduction, just moving your foot in a circle that's going to be fixed at the hip, so just doing like a hip circle with your foot off the ground would be circumduction, hip circumduction. Now, something else to think about, we have, oh, thank goodness, we've got this, what's called lumbar pelvic rhythm. So when my spine or when my hip does something, my pelvis does something, okay? So, or let's look at this on the left-hand side, lower left-hand side. When I go into trunk flexion, I flex my spine forward, at a certain point, my pelvis is going to have to follow suit. So as my spine moves forward, I'm doing a bend like this, and let's say I go down and touch my toes, and here's my pelvis is going to do an anterior pelvic tilt. And the easiest way to remember this is anterior is to the front side, posterior is to the back side. So the pelvis is going to be like a bucket of water. When the bucket of water tilts forward, lets the water flow forward, that's an anterior pelvic tilt. When that same bucket of water moves backwards, the water pours out the backside, that's going to be a posterior pelvic tilt. So trunk flexion, at a certain point, if I stand up and flex forward, my pelvis is going to come forward like this. It's going to be an anterior pelvic tilt. Trunk extension, let's say I stand and I try and reach all the way behind me, my hips are going to move towards the backside. So it's going to be backwards, posterior pelvic tilt. The water pours out backwards. And then when I lean to one side, so let's say I'm going to flex my spine, lateral flexion, I'm going to get opposite side contralateral elevation. So when I go one way, the other side actually has to raise up. And when I do rotation of start rotating through my hips, through my spine, my lumbar spine, I'm going to start to rotate that portion. My sacrum is fixed, so it's going to have to move. So we're going to get ipsilateral, which means same side, sacral rotation. So that kind of moves as one piece that way. You can't really disassociate lumbar spine, but we just generally describe it this way. Now, this is trunk-initiated lumbar pelvic rhythm. So everything that happens with the upper body. Now, what happens if it's the lower body or the hip doing the movement? So when we get into hip flexion, we're going to say, let's imagine I'm hanging, and I raise my legs up as high as I can to the point where I start to bring my knees up towards my chest. You're going to get into what's called the posterior pelvic tilt, right? Because the water is going to start to pour out backwards out of the hips. And if I lay on the ground and I raise my legs up as high as I can and try and bring my hips up off the floor, I'm laying on the ground on my stomach, I'm going to go into an anterior pelvic tilt. If I go into hip abduction, so bringing the leg to the side, I'm going to get same side elevation. So when I bring my left leg to the side, away from the midline, it's going to hike up. And then the opposite side, when my hip hikes up on one side this way, It's got height down on the other, so you get this. Um, it always is going to play out this way: ipsilateral elevation and opposite side depression. So one side goes up, one side goes down. This is depression. This is going to be the elevation. Same side elevation, opposite side depression, and then hip adduction back to the midline. Think about bringing your leg all the way across the midline. You're going to get the opposite. You're going to get ipsilateral depression, same side depression, and opposite side elevation. And then if we rotate the hips, so think about kind of just doing little hip circles, you're going to get the L5 is going to also rotate in the same direction. So we call that ipsilateral rotation. What you see in the very last bullet point is we have to be mindful of the L5, S1, really L4, L3 as well. The interfaces of those vertebrae, and we'll talk about this in a second. This becomes problematic if we move incorrectly, especially under load. We want to make sure that we're balanced out whenever we're doing things like squats. And let's take a peek at this in a second. Here is the general normal ranges of motion. There's no quiz questions on this, so don't stress about this. I've given you way too much already to kind of stress out about. But if you're curious as to, well, at what point should I go into this movement, generally, there's normal range of motion, and that's how we generally know if someone has an imbalance, because they won't meet the minimum requirements for that range of motion in whatever joint action they're looking at, which is on the left-hand side. So you're going to see what happens. But what I want to talk about, and we'll show you in a picture in 2 more slides, is this thing called a posterior pelvic tilt while under load is contraindicated. Contraindicated means not recommended. It's not recommended, not something you should be doing. So think about the vertebrae. They're stacked, and in between we have the discs, and we'll look at a picture of this in a second. But if my hips go into a posterior pelvic tilt, let's say when I'm squatting, I think it's easier to see here. You see this guy, when he squats all the way down, he's going what sometimes in gym bro culture is called astergrass. And you see what happens is the low back curves out. He's going in because the pelvis is going into a posterior pelvic tilt, and he's rounding out his low back. This is a problem. Not here unloaded, but it is a problem if he has a whole heck of a lot of weight on his back, like in a deadlift and or a squat in particular. Now on the right hand side, you see he's cleaned that up a little bit. He's probably gone a little wider. He's sitting. His chest is up a little taller. You can see that he's got those weightlifting shoes on as well. That actually helps. You're going to see. Notice in the first photo, his tibia, his shin, the angle he's a little more vertical. And then when you look at the right side, you see his knee and shin is a little bit more forward. So he's shifted his weight forward, because here's the deal. Your feet make up the base of support under your center of mass, which is going to be in your pelvis. Now, this guy happens to have a good relationship between femur, tibia, ankle range of motion, pelvis. He's exaggerating the one on the left just to show us. But on the right, he's able to do it, and he's able to keep his center of mass. You see his ears and his head and neck. They're pretty much right over the kind of the heel to mid part of the foot. He's got no problem there. Some of us don't have those same mechanical lengths of our joints, or we have excessive tightness. And so you might notice that people go up on their toes, their heels pop up. These are all telltale signs of either structurally we need to make some modifications, because let's say you had a longer femur, a longer thigh bone, that's going to totally throw off how effectively you're able to squat. So biomechanics and anatomy play into this. We don't all have the same length bones. We also don't have and if you're excessively tight, maybe you haven't been as active as you should be, or you don't work on flexibility. That also will contribute to this. So the big issue, though, is what's happening at the lumbar spine. So let's look at this slide. And you see the front part of the lumbar spine where the arrows are is because he's now in he's got rounded pelvis, right? He's dumping into a posterior pelvic tilt. That's turning the vertebrae like this, or I think it's better if it looks this way. and you're getting more compression on one side of the vertebrae, which is pushing and squeezing the nucleus of the disc, what's called the nucleus pulposa. You don't need to know any of this. And it's pushing the contents posterior, and over time, the rings of the disc will crack and that nucleus will seep through. And then eventually it actually will push all the way on the last layer of cartilage, and that becomes a disc bulge. And in that space just behind in between the bones of the left-hand side and the round vertebrae, that's where your spinal cord is. So if that starts to bulge out, like you can see the arrows pointing towards that open area, that would compress the spinal cord and cause all sorts of pain and loss of ability to send signals, cause drop foot, can cause excruciating sciatica, all sorts of problems. And if that last layer of cartilage breaks, then we have what's called a disc herniation. And now the bones no longer have the nice cartilage cushion, and now they're bone on bone, and now you're going to run into arthritis and all sorts of other problems. Now, I have this, I probably should have taken this out, but it's kind of interesting. The guy on the right, he's doing a Atlas stone lift, and at our LACC gym, we have Atlas stones. They're not stone, but we actually have what are called Dynamax balls. We have a 150-pound Atlas stone, a 100-pound Atlas stone, or like a 120-pound Atlas stone, and then a 75. And so we can have some fun doing some strongman type training work in our gym. So if you ever want to check out what we got pretty cool facility for some really awesome stuff. But my question mark on there is you see his spine is flexed. Now he's not really in a posterior pelvic tilt, but you do see that his upper body is flexed. So this is where we get into some of the research. The research has shown that when guys are doing, or men or women are doing Atlas stone lifting, there's excessive amounts of bracing right up against the stone itself with the abdomen, so that it's actually not causing the same type of compressive or shear stress. The shear stress looks like this across the spine that you would typically get if you put that boulder on his back and shaped his back like that and did a squat with it, or did squatting with a bar on his back and he had that rounded out back. So that's kind of an interesting tidbit. Seems to be safer and doesn't have the same structural problems that squatting, doing ass to grass, and having a rounded out posterior pelvic tilts squat with your hips all the way posteriorly pelvic tilted causes on the lumbar spine. All right, enough of that. Moving on to elbow. Two possible movements at the elbow. The elbow is always in the sagittal plane. It's going to be flexion and extension. So I think that's the easiest way to kind of remember this stuff. Elbow flexion, I'm flexing my bicep. Elbow flexion, the joint angle is getting smaller. Elbow extension, joint angle is getting bigger. And you see that in the picture there. Okay, we have four movements in the knee. We have flexion and extension. Those are going to be sagittal planes. So the knee, you can see there on the right-hand side, the knee, the heel coming down towards the butt eventually would be flexion. The knee straightening out is going to be extension. And then there is a little bit of rotation in the knee. And if you want to play this video, you're going to see this guy. He's able to hold his femur and he's able to kind of move the tibia with a little bit of rotation in there. So we should have a little bit of rotation in that knee. But predominantly, we're always going to refer to the knee as more of a sagittal-based. It's primarily sagittal-based. We don't get a lot of other movement out of it. All right. And then we have the forearms. So the forearm is anatomical position is going to be thumbs out. And so that is going to be supination, and then pronation will be thumbs in. And you can see when the thumb goes in, you bring your thumb towards your midline. The radius crosses over the ulna bone. And the easiest way to remember that is supination is like you're holding bowls of soup. Pronation would be the opposite of that. The wrist has four movements. It's going to be in the sagittal plane and in the frontal plane. So adduction, again, anatomical position. Here's neutral. Abduction is away. Adduction is towards. And then extension this way, flexion this way. And the fingers also do flexion and extension, abduction and adduction as well. But smaller stuff we don't care so much about. But if you ever are interested in getting more into hand work, that's an occupational therapist specialty. Occupational therapists are called, can work towards a hand specialist credential, and they are the ones that actually work on rehabbing hands, not physical therapists. Now, the ankle has two movements, and it's sagittal plane based, but instead of saying extension, we say plantar flexion. So dorsiflexion is when the foot goes or the toes go up. Plantar flexion is when the toes point into the ground. So it's one of those you just have to memorize. And then the foot also has what we call inversion. The sole of the foot goes in, and then eversion, sole of the foot goes out. And then just a couple other things we need to kind of just talk about. A single joint versus multi-joint. So obviously the woman on the left is doing a single joint. She's doing elbow flexion, so it's known as a bicep curl. But, kinesiologists say, well, it's elbow flexion. Because elbow flexion can happen in all sorts of different ways. The exercise is going to dictate that, but we want to stay consistent that elbow flexion is elbow flexion. And that's a single joint movement. Now, it doesn't mean that the muscles of the shoulder don't stabilize. The shoulder girdle is going to stabilize. So those muscles are working, but the primary work is going to be in the concentric, the muscle shortening phase when she's doing that curl, working on that bicep. And then the gentleman on the right side, he's got multiple joints engaged. He's got the hip, knee, and the ankle. And he's going to stand up. And when he stands up, the muscles will contract. That's the concentric phase, muscle shortening against resistance. And that is what we sometimes call triple extension. Now, the question is, bang for buck, which exercise is going to be more effective? Let's say a pull-up or a bicep curl, or compared to a knee extension or a squat. And the answer should be the multi-joint exercises, because bang for buck, we can pull more weight, move more weight with a multi-joint exercise than we can do with a single joint. And so if we have limited time from a training perspective, we want to prioritize multi-joint before single joint. And always do multi-joint exercises. If time is of the essence, you can't get to single joints. It's much better to do multi-joints because that's how we're structurally organized. We can move more weight with our multiple joints working together. Now, a couple things to think about is the isometric, isotonic, and isokinetic. I don't have isokinetic on here, but isometric, if you look at the definition, it means the muscles neither shortening nor lengthening, but it's moving. So think of a plank, think of a wall sit in a plank, your abs are working. The muscles are neither lengthening nor shortening, but they are working, they're holding their position. So that's an isometric contraction. Isotonic contraction is where the muscle is actually contracting against resistance. So in the bicep curl there, the middle one, if we do elbow flexion, you see the arrow going towards the shoulder, we're going elbow flexion. That's the concentric phase, the muscle shortening against resistance. In the eccentric phase, if I slowly do what's called the negative, that's the eccentric phase. And the muscle is lengthening against resistance. Now, human beings are stronger in the eccentric phase. We can do more weight in the eccentric than we can in the concentric. The last one it's not on here, but there's isokinetic. And that means that the muscle tension is moving consistently against the resistance. So the resistance itself, there comes a point when you're doing a bicep curl where you have it gets hard and then it gets easier when you get to the top, or it gets a little easier to the bottom. The sticking point is usually when the weight is furthest away from the body. And so in an isokinetic contraction, the muscle is working the same throughout the full range of motion. It's a little bit different, and you need a special machine, piece of equipment to make that happen, because we can't do that with just regular gravity. All right, we have unilateral, and which is going to be one side, one joint. So this guy on the right, he's doing a incline, almost a shoulder press. He's doing one shoulder at a time, this will be unilateral one. This will be alternating this way, and then we can do reciprocal, whereas one's going up, the other's going down. It's a little bit more like a piston. Ipsilateral is going to be the same side. So you're going to see this gentleman, this olden-timey gentleman here. He's doing knee extension with hip flexion, and then he would he'd go into hip extension and knee flexion to bring his leg down at the same movements on the same side. We have bilateral, basically using two appendages at the same time in the same way. So she's doing a chest fly, pretty typical. There's that reciprocal where he's alternating sides as he's doing the chest press. And then we have opposite side. This is the bird dog exercise. You see her left arm and her right leg are moving, but that's opposite sides of the body. It's a very good core exercise. And that is all I have. So hopefully this helps explain a little bit of the joint action, the planes of motion. Please watch the videos. And you have multiple attempts at the test, which is designed purposefully so that you can actually start to use the testing and the quizzing, as a study device. So please take advantage of that and really try and learn this stuff because it's really, really important for you to be able to communicate human movement through the language of a kinesiologist, because otherwise there is no way. We have different names of exercises. Everyone's got their own kind of flavor of exercises. So why this really matters is we need to have a very specific language that's going to allow us to communicate with one another about what we should be seeing. A really good kind of practical example is when a physical therapist sends me information after I'm intaking a client who's finished up with physical therapy, or I'm working in collaboration with a physical therapist. They'll say, hey, let's avoid spinal flexion, or let's avoid shoulder flexion. They're dealing with shoulder impingement. Let's work on scapular retraction and depression. And so now you have to know what that means so you don't look like an idiot. And of course, part of this is just you got to memorize it. This is part of functional anatomy stuff. And the reason why we're doing it here at Exercise Phys is because I want to make sure everyone's on the same page. We're going to talk about some movement, some exercises along the way, and it's important that we have this foundation. So do your best. I know this gets hard. If you take more courses with me, you're going to get this time and time again. It becomes a little bit easier the more you do, and there's going to be some people in this course right now who have said, yep, absolutely, I've got this stuff memorized. This is review for me. So hopefully one day you can be one of them. All right, talk to you soon. Any questions, just let me know.